In your book, Surgery, the Ultimate Placebo, chapter one is called The Placebo Effect. What is the placebo effect and how does it work? What was this about?
Yeah, that's a good question. It's actually a difficult concept. Most people understand the idea of a placebo pill. You know, the idea that you could take something that doesn't actually do anything in itself, but might still have some effect. When it comes to placebo surgery, it's a lot more difficult for people to understand the concept that you would do an operation on somebody that would not actually do anything. Um, but that's actually what we're talking about. We're talking about operations that are done on people that don't have an effect in themselves. And then we have to explain why the patient felt better afterwards. Um, Now, some people call that the placebo effect. Um, but really it's due to lots of different things. And the reason why somebody may feel better after surgery could be, for example, that they would have felt better anyway, even if they had not had the surgery. So for self-limiting conditions or conditions that kind of get better anyway, um, it's a classic example would be a condition called tennis elbow. Most people have heard of that. They know what that is. And for a long time, we did lots of operations on people with tennis elbow. We did different kinds of surgeries to try and fix this tennis elbow problem. And the surgeries, by and large, worked. And that's because if you don't do anything to tennis elbow, if you do absolutely nothing to the patient, 98% of them will get better within 12 months. And so surgery, so people can call that a placebo effect of the surgery, but you could also call it a no effect of the surgery. But either way, it's this problem where people get better, but it's not due to the surgery. And so that's what I've kind of defined as the placebo effect for the sake of argument during the book.
In your book, Surgery, the Ultimate Placebo, chapter two is called The Science of Medicine or Lack of It. What makes good science? What was this about?
This chapter was really had to be put in there because this is the answer to everything, and the way we answer questions in the world today is by using science. I wouldn't have thought that that was really very contentious. I would have thought that most people would understand that, but it's surprising how people misread science. And for instance, there's lots of examples where science has got it wrong, you know, for sure. And so the conclusion that some people have then is that, oh, science is bad. Science is not a good way of knowing things because it's often wrong. Um, but I, in the book as well, I often paraphrase Winston Churchill, who said of democracy that democracy was the worst system of government except for all the others. And so I kind of say that science is the worst way of knowing things, except all the others, except for all the other ways. But by definition, science is a method of error reduction. It doesn't always give you the right answer, but if you do it properly, it will give you the least wrong answer. So it's kind of like the best we've got. And so I spend that chapter just sort of defining what science is and explaining why we should rely on it, you know, when we're trying to work out whether things work or not.
In your book, Surgery, the Ultimate Placebo, chapter three is called Building the Perfect Placebo. What makes a good placebo? What was this about?
Yeah, so this chapter just describes the evidence that we have and the experiments that have been done looking at placebo responses. And so, for example, even within placebo pills, we know that the size of the pill can have a stronger effect. The color of the pill can have a different effect. We know that two pills are stronger than one pill in regards to the placebo effect. And if people are made to believe that the pill is an expensive pill, it has a stronger effect than if they believe it to be a cheap pill. And then going on from pills, we know that more invasive things like injections have a stronger effect than pills. And so if you, this is the argument of the book, if you were to build the ultimate placebo, it would be something that would be very invasive, it would be very expensive, it would involve devices, implants, and basically surgery would be kind of the ultimate placebo.
In your book, Surgery, the Ultimate Placebo, chapter 4 is called Putting Surgery to the Placebo Test, Examples of Studies Using Sham Surgery. What was this about?
Yeah, so again, comparing it to pills, most people know and understand that to test a new drug or a new pill, you would compare it to a pretend pill. You would do a placebo-controlled study to find out whether that pill works. And most people know that that's probably the best way of finding out whether it works or not, because everything else is the same. The only difference between the two groups in such a study is that one got the real drug and one didn't get the real drug. And so any response difference you see is due to the drug. But people don't think that that's a doable thing in surgery. That myth has been busted a lot in, I'd say, the last 10 years, but not much more than that. And it's really only sort of in this century that placebo surgery studies have been more common and more routine. And this idea of doing an operation where half the patients will get the real operation and half the patients will get a pretend operation sounds very scary. It's like, how could you do something like that? When you think of it scientifically, that's the best way. Like, there's no better way of finding out whether the surgery works or not than doing that. And people argue, they say, well, that's unethical. But there's a whole argument to be had there, because I would argue that what's unethical is doing surgery on people when we don't know if it works or not. That's unethical. Finding out if it works or not is ethical. And then you can apply it or not apply it to all millions of patients in the future. And so I described some of the tests that have been done. And interestingly, when a lot of procedures are put to the placebo test, procedures that we thought were effective suddenly are being shown to be completely ineffective or no better than placebo. And this has driven the demand for maybe more tests like this on surgery. Why haven't we been doing more in the past? That kind of thing.
In your book, Surgery, the Ultimate Placebo, chapter 5 is called The Surgical Scrap Heap, Operations That Have Faded Away Due to Lack of Effectiveness. What was this about? Here
I go through a list of surgical procedures that are no longer being done because we thought they were necessary, but tests have shown that they didn't work. I actually take a little bit of liberty here, and I go all the way back through history and talk about things. And so I start off with bloodletting, and that's important for surgery because surgeons themselves used to do bloodletting. They would cut people with a lancet and bleed them to cure them of all sorts of conditions. And this was a mainstay of medical and surgical therapy for thousands of years, really. And it was never effective at doing anything except people thought it was effective. The reason they thought it was effective is because a lot of people got better afterwards. But of course, they would have got better anyway. In fact, some of them probably got worse because of the treatment. But I take it right up through, recent history and even my own training. One example I give was when I was doing my very early surgical training, when I was a junior resident. I did a couple of terms on general surgery, and they would do mastectomies for breast cancer. And in those days, way back in the 80s and even earlier than that, in the 70s, there was this sort of race to do the most radical mastectomy that you possibly could. And so surgeons started off by taking out the cancer, and then they took out the whole breast, and then they took out the breast and the muscles around it. Then they started sort of lifting all the structures off the chest wall, and these were horribly, disfiguring, major operations. And it turns out they're completely unnecessary. It didn't really make any difference to the risk of death for the patient. It was just this sort of thinking, it sounded like a good idea that the more radical, and so surgeons would try and outdo each other with, how radical they could do these mastectomies. And these terrible disfiguring operations were largely a waste of time. And of course, they're not done now. Now, they would do sort of lumpectomies, things like that. But at the time, it was a good example of how something sounds like a good idea, but had never been tested properly. And unfortunately, that supports a lot of surgery these days, is that it's based on something that sounds like a good idea, but has not been rigorously scientifically tested. And when it is, it often fails.
In your book, Surgery, the Ultimate Placebo, Chapter 6 is called Today's Placebo Surgeries, Current Surgical Procedures Under Question. What was this about?
So this is operations that we are doing now. These are current, common surgical procedures that have not been adequately tested, certainly haven't been tested against the placebo, and maybe the operations that in 20 years' time we look back and say, gee, what were we thinking doing all these crazy operations? And so I cover a lot of things, some things that maybe don't work, like spine fusion for back pain, some arthroscopic keyhole procedures we do, like on the shoulder. I think that we might not be doing so many of them in the future. And some operations where maybe there is a need for it, but we're probably overdoing it. And I even talk about some obstetric operations like a hysterectomy and cesarean section, where and prostatectomy for prostate cancer and things like that. And I think there is some evidence that we've been overdoing these operations, because recent data shows that the rates of these operations, or many of these operations, are falling, which would indicate that we were probably doing too many of them. Not to say that there's no place for them whatsoever.
In your book, Surgery, the Ultimate Placebo, Chapter 7 is called Why Do We Still Do It? Reasons Behind the Persistence of Surgery That Is Not Effective. What was this about?
Yeah, this chapter is very important to me, because this lists the reasons why surgeons still operate, even though we know that the procedure doesn't work, or we highly suspect it doesn't work, or there's no evidence for it. And the question I get is, well, then why are surgeons doing it? Like, it doesn't make any sense. If you've got evidence that something doesn't work, how come surgeons are still doing it? Surely it must work, And so I kind of take that apart and I look at the reasons why. I cover things like financial incentives, and certainly that's probably part of it, because we know that there's a big difference in the rates of surgery based on how surgeons are paid. And so spine fusion surgery is very common in the US, because surgeons get very well paid to do that kind of surgery. In the UK, where surgeons are salaried and they get paid the same whether they treat something surgically or non-surgically, the rates are like 10 times lower. And so that, there's some evidence that there's financial incentives. Another reason is because surgeons don't always understand the science. People think that doctors are great scientists. They're not. We don't get taught to think critically and to think scientifically. I was not taught that. I had to go away and learn it after I did medicine and after I did surgery. And so a better scientific understanding would help surgeons a little bit make better decisions. But the bottom line is that the reason why surgeons still operate and do procedures that might not work is because the surgeons believe that it does work. And that sounds fairly simple, but what I'm trying to say when I say that is surgeons aren't going out there deliberately trying to deceive people. Surgeons don't wake up in the morning thinking, oh, I'm going to do a couple of these operations today, and I know it's rubbish, but I'm just going to get some money out of it. They don't think like that. You know, I'm not completely cynical. I'm skeptical, but I'm not cynical. And I think that 99% of surgeons out there think that they're doing a good job and they're trying to do the right thing. It's just that they're not always right when they do that. And the example I give is I equate it to homeopaths. So homeopathy has been shown, scientifically to have sort of no effect. It's basically water that they're giving people, and they're relying on the fact that people get better anyway to justify it. But homeopaths don't wake up in the morning thinking they're going to go and rip off 30 patients in their clinic today by selling them rubbish. They wake up thinking that they're making a difference and that what they do really works. And it's no different with surgeons.
In your book, Surgery, the Ultimate Placebo, Chapter 8 is called Surgery Has a Placebo Effect. So what? The case against using the placebo effect. What was this about?
I added this chapter after I was out at a social dinner with surgical colleagues, and one very famous placebo surgery study had just been released recently, showing that a very common orthopaedic procedure, which was knee arthroscopic surgery for cartilage tears or meniscus tears in the knee, was no better than placebo. And this was a bombshell article. Everyone was talking about it. It was really big news. And it showed that this common procedure probably just didn't work and wasn't necessary. And one friend of mine said, yeah, this paper's great. He's going to be doing more knee arthroscopies than ever after this paper. And I kind of scratching my head, just thinking, what do you mean? This paper showed that it doesn't work. And he said, yeah, but 2/3 of the patients in the surgical group got better. And I said, yeah, but 2/3 of the patients in the placebo group got better. And he goes, yeah, so 2/3 of the patients got better. That's great. These are good results. I'm going to keep doing the procedure. I don't care if it's a placebo or not. So that's the title of the chapter was, so it's a placebo. So what? Hey, if it works, I'll keep doing it. And that really surprised me. But ever since then, whenever I've given lectures and people have asked questions of me, they often ask this question. They say, well, so what if it's a placebo? As long as it's working and everybody's happy, what are you trying to do here? And that really kind of shocked me. So I had to go away and think about what's wrong with that. And so I point out that there's several things wrong with that. One is that it's unscientific, it's deceptive. We're either fooling ourselves or fooling the patient into thinking the procedure works. It costs a lot of money. I mean, surgery is not a placebo pill. Surgery is a major procedure and it also carries risks. So we're harming people. We're costing the system and the patient a lot of money. We're fooling ourselves. And the other thing that I say is that as soon as we embrace the placebo as a reasonable treatment, then as medical practitioners, we have removed the only real barrier that exists between mainstream medicine and alternatives to medicine. Because the alternatives to medicine, the homeopathy that I mentioned earlier, rely on this placebo effect. And they're really embracing the placebo effect when they give people water to fend off their illness. So as soon as we start doing that as surgeons, then we cannot criticize acupuncturists, homeopaths, naturopaths, or anybody else. So it basically wipes out scientific medicine and just makes it a free-for-all.
In your book, Surgery, the Ultimate Placebo, Chapter 9 is called What Can We Do About It as Patients, Doctors, Researchers, Funders, and as a Society? What was this about?
I always try and end every message or every lecture with a kind of positive message. Like, I'm really good at highlighting the problems, but I'm not so good at solving them. And I think that it's incumbent on anybody who is highlighting a problem to at least give some thought to what the solutions are. So that was the idea behind this chapter. And I talked about what doctors could do. So, for example, doctors could be trained better to be more scientific, to understand the evidence better. And I also talk about what patients can do. And this, again, is another very common question I get when I give my lectures and talks, is what questions should the patient be asking? What can the patient do to not be operated on unnecessarily? The first thing I like to do is say that the public should be more scientific. There should be more scientific training, not just of medical practitioners, but of everybody. Everybody at school should be taught a little bit more about critical thinking and logical flaws and what's wrong with the way science is done sometimes and how could it be done better. But specifically, when a patient has a problem that they go and see a doctor, the questions that they can ask their doctor are many, but the core question they should really be asking is, what evidence is there that doing this operation on me is better for me than not doing the operation? Now, that sounds like a super simple question. Like, that's a question you shouldn't even need to ask. That's like basic thing, but it's often not asked and it's often not stated by the surgeon. It's often kind of like, well, you've got a tear in your meniscus. You can see here on the scan, there's a little tear there. So we can go in there and we can cut out that loose tear. And that sounds great. It sounds like it might be a good idea, but nobody is discussing the alternatives of not doing the operation. And if the surgeon said, well, we could do an operation where we go in there and cut out that meniscus, but you're no more likely to be better in 6 weeks or 6 months than if we don't do it. So therefore, I don't think you should have it done. That bit often doesn't follow. And so it's up to the patient to say, oh, okay, doc, you're recommending a knee arthroscopy on me. Tell me, what evidence do you have that having that knee arthroscopy is better for me than, on average, than not having the knee arthroscopy? And then they'd be forced to sort of think about it.
Why did you write the book Surgery, the Ultimate Placebo? A surgeon cuts through the evidence. What was this about?
Yeah, that's a good question. I have been, lecturing and researching on the effectiveness of surgery and the effectiveness of medicine for a while, but mainly communicating with other practitioners. And there's a whole lot of people out there, I'm not alone, who are preaching the problems of too much medicine, of over-treatment that occurs within medicine, and wasted medicine where we're doing what we call low-value care, procedures that have very little yield but cost a lot of money. But I was finding that this was not really well understood or well advertised outside of the medical community. So one of the reasons I wrote the book was to get the message out to a wider audience. So it's aimed at everybody. It's not aimed at doctors, although doctors probably are the ones that most commonly read it. And certainly it's also aimed at them, but it's written in a way that the general public would find it an easy read. I've taken all the technical stuff out of it. And so I'm trying to broaden the audience for this kind of message.
Which surgeries do you believe have the least evidence for their effectiveness?
There's a lot of surgeries, and probably about half of the surgeries that are done in the world don't have very good evidence that they work. But some very common ones would be, I think that spine fusion surgery is probably overdone. It's very common surgery. It's certainly not the most common surgery done, but it's very common. It's particularly common in the US. And not only is it fairly common, it's very expensive. So it's probably one of the most expensive common surgical procedures, partly because of the scale of the surgery. It's quite a big operation, but also the cost of the devices and implants that are inserted. They cost many tens of thousands of dollars per case. So you're looking at, procedures that cost upwards of $100,000. So this is a very expensive procedure, and the evidence for it in fixing people with chronic back pain is not very good at all. But I think there's lots of other, perhaps smaller procedures and cheaper procedures and probably safer procedures. But I often highlight that one because this is a really big, risky procedure. There's a lot of blood loss associated with a lot of complications. It's a huge expense to society, and it's something we really don't have good evidence for.
Which surgeries do you believe are worth getting?
I think there's probably a lot of operations out there that are very effective. And the examples that I give in the book, a classic example is cataract surgery. And I like that example because it is very common. It's hugely common. I mean, cataract surgery is done all over the world, even in developing countries. It can be done for like a few dollars, literally a few dollars for the lenses, and people donate their time. And so you get a lot of eye surgeons who travel around the world doing this procedure on an industrial scale. And it's a procedure where you can actually test someone's vision beforehand, and their vision can be very much impaired. So they have very poor reading ability. You pop in this lens that you can buy for a few dollars. You can do the procedure under local anesthetic in a short time. And these days it's such a common procedure that it's really bread and butter, reasonably safe surgery for most eye surgeons would do, hundreds of these, if not thousands. And you can test their vision afterwards, and it can be excellent. And so you've got someone who can't see and now they can, and you've done it for a few dollars. So to me, that's a good example of how surgery can be a good, can do good in the world. There's lots of other examples, but I just like to highlight that one because it's widespread, it's cheap, and it's very effective. Now, there haven't been any placebo studies comparing that to not doing it, but the outcomes are fairly objective. So I don't think you really need to do the study, because if you've got someone with really bad vision from a cataract, you can do nothing to them, and I'd be pretty surprised if their vision got any better if you didn't do anything, because it's not the kind of thing that gets better on its own.
Do our minds have the power to influence our health, and can they get rid of diseases?
Certainly our minds have the ability to influence our perception of our health. So when it comes to subjective things like pain would be the biggest one, but also mood, depression and how we feel. But pain is a big one because a lot of surgery is done for pain. And yes, the mind and as a general concept, but our circumstances as well can influence our level of pain, and particularly how we react to the pain. And one good way of thinking about this is contrasting pain to suffering. And I've been around for a long time. I've seen lots of people in pain. I've seen lots of people with broken bones and with painful conditions. And the reaction to this pain varies quite a lot. And so arthritis is a good example. You can see people with arthritic changes in their back or in their knee, which is fairly common. And some people just cope very well. Yeah, it hurts, but it doesn't worry me too much. I know what it is, and I'm happy with it, and I just sort of get along with life, and I adapt, and I sort of work around it, and it doesn't influence me too much, and I don't get depressed about it, and I don't lie awake thinking about it. And you can get somebody else with the same or even less severe arthritis whose life is ruined because of it, because they're just kind of like, oh my God, it's terrible. I'm going to end up a cripple. I just, every time I take a step, I can feel this pain, and it's just worrying me so much. I don't know what's going to happen to me. And these people are miserable, and yet somebody else with the same condition who also has pain every step they take doesn't worry about it so much. And so there's a huge spectrum of how people react to pain, and a lot of that's got to do with the circumstances they're in as well. A lot of my research looks at compensation, the effect of compensation on people's health and people's pain and response to surgery. And that's not a well understood phenomenon, but certainly it does make a difference. The blame. So, for instance, if you were in a car accident and you were backing out of the driveway and you backed into a telegraph pole or something, and there was no one else around, and you did it, and you kind of hurt your neck a little bit, and you'd feel like an idiot because it was all your own fault, and you're kind of like, oh, what am I doing, and your neck might be hurt a little bit for a little while, but you're not going to pay any attention to it, and you're too embarrassed to even talk about it. And then maybe 6 weeks later you might not think about it that much, and then yeah, I still feel a little bit in my neck, but that's not worrying me that much. It's not as bad as it was before, and I'll get over it. And then you never pay any attention to it again. Same thing. You're sitting in your car, and instead of you backing into a telegraph pole, a person drives into the back of you while you're waiting at the lights. It's exactly the same mechanism. It could be exactly the same amount of force, and you can have exactly the amount of pain in your neck at the time. But if it's someone else's fault, it's kind of like, oh, I've got this neck pain in it, and it's all his fault. What an idiot. I hate that guy. I can't believe he did that. I'm going to sue him. I'm going to make him pay for this. This is terrible. Look what he's done to me, And then 6 weeks later, when you feel the pain, just like you would have anyway, you're kind of like, oh my God, it's been 6 weeks and I'm still getting the pain. When's it ever going to end? This is ruining my life. And so your reaction to it is completely dictated by the circumstances of the accident and who you blame, rather than the mechanical force that caused it. And so these are just a couple of little sort of thought experiments that show you that pain is, well, I guess it's subjective. It depends on a lot of things.
Do other surgeons or parts of the medical industry agree with your conclusions?
Yeah, for sure. There's, this is another myth I like to dispel, is that I'm not some crackpot or lone voice out there. I'm a very small part of a very large group. There's international conferences that are convened on overdiagnosis and overtreatment, and the excesses of medicine and the ineffectiveness of medicine and how we can do it better. There's whole issues of major journals like the BMJ and the JAMA and the Lancet, which are dedicated to this problem of overtreatment, too much medicine.
Is the medical industry studying the effectiveness of surgery and stopping any surgery that the risks outweigh the benefits?
Yeah, it's a very slow process, but there are more and more studies being done scientifically evaluating the effectiveness of surgery. These aren't always placebo studies. It could be a study comparing surgery to a non-operative alternative like, physical therapy or something like that. There are more of these studies being done, and the studies that are being done are of better quality than the studies that used to be done. So the science is better, and we're getting a better answer of how effective surgery is. And sometimes that shows us that the surgery, is effective, and that's great. And if it does, I'm all for it, and that surgery should be done. But sometimes it's showing that the surgery is not as effective as we thought, and in which case we should be weeding out those things. So, I guess what I like to say is that science wins out in the end. We're going to find out what works and what doesn't, but the process is very slow. Each study takes years to do. You need lots of studies before you can really make firm conclusions, and it's going to take a long time. So these things don't happen as quickly as you would think they do.
How effective is prostate surgery to remove a growth that might be malignant?
Yeah, so probably not as effective as you think. Prostate cancer is common. In fact, it's the most common cancer in men. So it's exceedingly common. It's more common as you get older. The old saying was that you're more likely to die with prostate cancer than to die of prostate cancer. So, in other words, it's a kind of a chronic condition. It sits with you for many, many years, and often you will die of something else before prostate cancer kills you. So, it's not the kind of cancer, like lung cancer or some forms of lung cancer, which are very deadly, or pancreatic cancer, where the average life expectancy is like 6 months or something. These are terrible cancers. So prostate cancer is not like that. So the argument is having a big operation to take it out, is that effective? Does it actually change the risk of you dying? And it's not that clear. And so, for example, for a lot of people who are older, so over 60 or 70, people with mid-grade or low-grade cancers probably will not benefit from having the surgery. Is there a place for surgery? Yeah, probably. So again, this is the opposite end of the spectrum. You've got a younger patient with a long life expectancy, and you've got perhaps a high grade or a more what we call aggressive cancer. That patient may benefit from having their prostate removed. But again, it's not whether the operation should never be done at all. It's are we doing it too much? And I think we were, because if you look at the rates of prostate surgery, they're falling. And they fell a lot from, I think, the 90s was the peak, or the early 2000s, when there was a lot of prostate surgery. And you can see a big peak, a big ramp up, and then there was a decline afterwards. And so I think even the surgeons who were doing the operation must have agreed that they were probably doing it more often than was necessary.
Should you always use surgery to remove a cancerous growth in the body?
No, that's the thing. It sounds like a good idea, that if you see a lump or anything that's a tumor, then it should be cut out. I mean, it's pretty hard to argue against that, because it's such a strong, I don't know, heuristic. It's kind of a rule of thumb. It just sounds like it makes sense, but it doesn't. It's not true. Another example is in South Korea. They started a screening program. This was, I think, in the 90s, and they started looking at screening for cancers. We're going to detect them all early. We're going to find all these lumps, and we're just going to take them out, and that's going to stop people from getting cancer. And one of the cancers that they ended up looking at was thyroid cancer. Thyroid cancer is not that uncommon. And in fact, when you look at it, it's quite common. It's just that a lot of thyroid cancers would never kill you. They're just common small tumors that people probably should leave alone. And so what they did in Korea, everybody started getting scans, and they found heaps and heaps of these tumors. So the incidence of thyroid cancer went through the roof, because they didn't know people had thyroid cancer. People have always had thyroid cancer, but they were just detecting it now. And so they were referred for surgery, and they'd have their thyroid taken out. Now, what happened is they didn't save any lives. So the number of people dying of thyroid cancer every year didn't change, because they weren't taking out the bad thyroid cancers that were killing people. They were taking out these relatively benign or slow growing, or these types of cancers that were never going to kill the patient anyway, and they were subjecting them to surgery. And you think, wow, well, maybe better safe than sorry. But no, it caused huge problems, because when you take out the thyroid, you don't have any thyroid hormone. So you have to take a lifelong replacement of thyroid hormones. When you take out the thyroid, you can take out what's called the parathyroid, which are these tiny little glands that sit on the back of the thyroid. And if you take them out, that completely throws out your calcium metabolism, and you need constant control of that, and you need parathyroid hormone replacements to to make up for that. And the other thing that happens is the nerve that goes to your vocal cords runs very close to the thyroid gland. And sometimes when people take it out, you damage the nerve. And so a lot of people lost their voice from having this as well. And some people died from having the surgery. So there was these huge numbers of complications, thousands of complications across the country for no benefit. So no, just because something is there, it doesn't mean you should take it out. Same with prostate cancer. That's why not all prostate cancers are removed now. A lot of prostate cancers are left alone because a radical prostatectomy is a huge operation, and the men will often, very often, be incontinent and lose bladder function and lose sexual function, and that's a big deal. You're wearing pads, you can't have sex. This is a big deal for something that doesn't make you live any longer. So that's not a procedure that should be done on everybody with a prostate cancer.
Should women remove breasts to save their lives when they have breast cancer?
It depends on the type of cancer. So breast cancer is a bit like a lot of other cancers. There's a spectrum. And there's one very common condition called DCIS, which is now called ductal carcinoma in situ, which did not used to be called cancer. That was previously not labeled a cancer. Once it got labeled a cancer, people had to start taking it out. But it's really not clear that removing that, this is the very low-grade cancer, because there are cases when this cancer can go away by itself. So the question of whether it is a cancer or not, it's kind of on the borderline there. It's the lowest grade possible of cancers in the breast. And so there is an argument about whether that needs to be removed or not, or whether it can be treated by, rescanning the patient later, or by tablets that can reduce it or treat it. So it's not clear that that needs to be done. The other end of the spectrum is high-grade cancers and women with high risk for cancer. So like a high genetic risk and things like that. So somebody with a very high genetic risk for cancer, or somebody who has a high-grade cancer that is just localized to the breast, now they may benefit from having that removed. But these days, it's much less common to have the whole breast removed. Rather, they would have the tumor removed, and then have radiation therapy, chemotherapy, and other things to supplement that. But it's a spectrum, and certainly again it's like prostate, it's like thyroid. Just because there is something there, it doesn't mean that you need to have a complete mastectomy, and certainly that's not what's done these days.
Is your book based on your opinions or based on scientific data supporting what you're saying?
I would hope that it's based on scientific data, because that's the whole premise of my argument, is that we need to be more scientific. And the more scientific we are when we study these procedures, the less effective they get. So if you be completely unscientific about things, you say, yeah, sure, taking out a torn meniscus makes sense. Let's do it. That's my opinion. That's most knee surgeons' opinion. It makes sense. Once you start studying it scientifically, maybe it's not that effective. And once you study it really scientifically by doing a blinded placebo-controlled study, you find that it's not effective at all. So my argument is that the more scientific you are, the less effective things become. Yeah.
Do you recommend back surgery for people in back pain?
I do not. Back pain, chronic back pain is a difficult condition to treat. There's no doubt about that. It's very common, but often it's multifactorial, like a lot of chronic pain. People have pain that can't always be explained by the findings on an image alone. And what we're often treating when we fuse back pain, fuse patients' spines, when they complain of back pain, is we're seeing some degenerative changes or some wear and tear in the back. The disc is dehydrated. But these are very common findings, and they're very common findings in people who have no back pain. And often people who have quite severe back pain don't have much in the way of these findings. So the correlation between these findings and back pain is very poor. So to do a big procedure on somebody for something that isn't necessarily correlated doesn't make much sense to me. And the evidence for it working isn't very good. And there's lots of programs of non-operative care for people with chronic back pain, which focus on treating patients' perception of pain, like cognitive behavioral therapy, psychological therapies, exercise therapies, a combination of these, which can really help people. And there's lots of examples of people who have had terrible, disabling, crippling back pain who have come out of it fine because they've changed the way they're thinking, and they've done this without surgery. And so I'm sure spine surgeons would give me examples of patients that have felt better after having a spine fusion. I don't doubt that. But what I doubt is whether they're more likely to get better after a spine fusion than they would after one of these non-operative programs. And I don't think that evidence is there.
If you don't have surgery, how do you correct the problem?
Sometimes you can't, but sometimes there's non-operative ways of doing it. But I think what you're getting at is a common reason for surgery that I get from my colleagues is they say, well, the patient's had the problem for 6 months or a year. They've tried everything else, and non-operative treatment has failed. So therefore, we have to try surgery. That's the next step. Again, that sounds good. That sounds like a good idea, doesn't it? They've tried non-operative treatment, it didn't work, so clearly we have to try operative treatment. That kind of makes sense. My argument against that is that if the operative treatment doesn't work, if the evidence is that this provides no benefit over the natural history of the condition, or even trying non-operative treatment again, then it doesn't work. If it doesn't work, if you have a procedure that doesn't work, the failure of another treatment for that condition doesn't suddenly make it work. So if surgery for, I'll go back to knee meniscus, for example. If surgery for a degenerative tear of the meniscus, an age-related tear, which is a very common finding, if surgery for that condition doesn't work, the failure of a physical therapy program for that patient, or the failure of a knee injection, doesn't suddenly make that operation work. The operation just doesn't work. So the fact that they've failed non-operative treatment doesn't suddenly mean that surgery is going to be effective. It isn't effective and shouldn't be done.
If someone gets an MRI and they find a growth in their body, should they watch it carefully, biopsy it, or have surgery to remove it?
Yeah, it depends on what it is. But there is an argument out there that everybody should get a total body scan every year, or whatever intervals. And again, hey, that kind of makes sense. Gee, what a good idea. Why don't we just MRI everybody's whole body every year, and as soon as we see a lump, we take it out, then nobody would ever get cancer. It doesn't work like that. Because what would happen is that we would have a whole lot of operations. It would end up being like the South Korean thyroid problem, where everyone's getting the thyroid taken out and nobody's getting better because of it, and a lot of people are getting worse. And so it would lead to a whole lot of surgery, and it wouldn't help people. That's a difficult concept to get across. There's lots of reasons for it. One reason for it is this effect in screening. So we're talking really about a screening program where at intervals we screen people for something. And this is, mastectomy, mammogram screening programs. There's colon cancer screening programs. There's lots of screening programs out there. But let me tell you the problem with them. If you did it on that scale, you have to show me that the screening program works. And there are trials you can do. There's randomized trials where they test hundreds of thousands of women, for example, where they randomize them to either having regular mammograms or just leaving them alone. And that's the evidence that you need to show that it's effective. And interestingly, in some of those studies that have been done for mammograms, have not shown a significant difference in mortality, in death rates, by having the mammogram. Sure, you pick up a lot more cancers, but you don't save more lives. Partly because the cancers that kill you are the bad ones, and bad cancers come on very quickly. And so if you've got a really bad cancer that's aggressive, it's going to grow and you're going to pick up the lump and you're going to have surgery on it, that's going to happen in a matter of months. And that'll probably happen between your second yearly mammographies. And if you have a mammography every second year, the probability of picking up one of those cancers is very low. But the probability of picking up a cancer that was never going to kill you anyway because it was so slow growing is very high. Every 2 years, you're going to pick up that cancer. You could leave it alone, do another scan, another 2 years, you're going to see it again. So you're always going to pick up those cancers. You're not going to pick up these aggressive cancers that just come on like that, accelerate, and kill you. So prostate cancer is probably a good one because we know that's a highly aggressive cancer that kills people very quickly. I mean, it's a terrible cancer to have. But if you screened everybody every year for prostate cancer, you'd probably miss all of those, because they would come in between the screenings, or you'd catch them when it's too late. You'd see it and you go, yeah, you've got this terrible prostate cancer. Sorry, there's not much we can do about it. So yeah, you've picked it up, but you haven't saved anybody.
So how do you know when to have surgery and when not to have it?
That's the trick. And that's why we have such a problem with surgery. We have huge geographic variations in surgery. We have huge intersurgeon variation in when people operate and when people don't. And for many common conditions that I see as an orthopaedic surgeon, broken heel bones, broken collarbones, shoulder pain, knee pain from degenerative menisci, even osteoarthritis, just very common conditions. You get some surgeons who will, operate on nearly every patient, and you get other surgeons who don't operate on nearly every patient. So that's the difficult bit, is working out when we should operate and when we shouldn't. That's why we need studies that tell us what is the benefit of doing surgery in this particular circumstance, and do those benefits outweigh the risks, and what are the relative benefits compared to not operating. It's a very difficult question to answer because it depends on the individual condition that the patient has, but that's the difficult question to answer.
Which surgeries do you feel best about, and which do you feel are the most unnecessary?
Yeah, I've mentioned cataract surgery. In my own field, which is orthopedic surgery, there's lots of very helpful procedures. Hip replacement and knee replacement are effective operations. There's perhaps some evidence that knee replacement, at least, is perhaps a little bit overdone, and the evidence I use for that is that it varies a lot between countries. So even in what we call developed countries, or modern countries where access to healthcare is not an issue, you have huge variation in the rates. So even where I live, in Australia and New Zealand are very similar economies. They're both very rich countries. Everybody's covered with health insurance. If you need a knee replacement, there's no problem getting it. There's no shortage of orthopedic surgeons. There's no shortage of hospitals. But the rates of surgery for knee replacement vary between those two countries, where we do a lot more in Australia than they do in New Zealand. And that's not always explained by differences in the population. I think that's an effective operation. Personally, I do a lot of hip fracture surgery. So elderly people who come in after a fall and they break their hip, I think that's a fairly effective operation. Studies have shown that we operate on them. We can get them walking straight away, get them home early. They don't have to. In the old days, they'd be lying around in hospital in traction for 3 or 6 months, which is a terrible way of treating anybody. So yeah, there's lots of effective surgeries, but there's lots of ineffective surgeries. I think there's some that have been shown to be ineffective that I've already mentioned, but there's probably some out there that we just don't know whether they're effective or not because they haven't been tested properly.
Are surgeries governed by a government agency, or is it up to each individual doctor?
It varies a lot between jurisdictions or between countries. So theoretically, surgeons can do whatever they want. Surgeons have a procedure that they want to do, for whatever, tennis elbow or shoulder bursitis or hip bursitis or anything they want. They can develop a procedure and they can do it, and often surgeons do. But if they want it to be covered by insurance, then in Australia, for example, it needs to be on the schedule, what we call the schedule or the list of approved procedures that carry a rebate. And if you make up a procedure that's not covered by that, you can do it, but the patient has to pay you out of their own pocket. It's not going to get reimbursed by their health insurer or the government. And I imagine, systems are reasonably similar around the world. So surgeons get a lot of flexibility about when to operate and what they do, but it's more difficult for them to get the patients to do it if it's not covered by their insurer.
What are your thoughts on C-section surgery? Does this save lives?
Yeah, so cesarean section, very common procedure. And, it's a bit like prostate surgery and the other things I've mentioned. Is there a case where cesarean section may save the life or save the baby? For sure. There's no doubt there's going to be cases where the baby's not coming out, there's an obstruction there or something, and something terrible is going to happen if you don't do a cesarean section. These cases exist. However, how do we explain the fact that cesarean rates vary widely between countries and between regions and between individual doctors and between hospitals? The World Health Organization has tried to limit this because we know that cesarean sections are overdone, and they originally said that the ideal rate should be somewhere around 10% of births. They changed that to, I think, 15% or something, and nobody really knows what the exact number is. But these are the numbers that have been bandied around. And yet you have some regions like in China and Brazil where the cesarean section rate is 50% of births. So half of all births are delivered by cesarean section. Well, that's crazy, and there's no way that amount is necessary. In the US and Australia, it's around a third, somewhere between 33%, or up to 35%, and that's considered too high as well. I mean, here you have a natural process. I mean, people have been giving birth for a long time. Do we really think that a third of all births need a cesarean section? I mean, that's a huge number. And are we considering the downside bad effects of having a cesarean section, the scarring that occurs, the need for further cesarean sections in later births, the other issues that occur with bonding, the risks of surgery themselves? Is it always necessary? And when you look into it, a lot of the reasons that obstetricians use to do a cesarean section are not well justified. And so you get this backlash against that, and you get birthing centers set up where it's midwife only. It's not run by an obstetrician. Now, sure, patients are sometimes selected where a really high risk patient who's perhaps got diabetes associated with pregnancy or blood pressure problems. Maybe that patient needs to be in a higher care unit. But in studies where they've compared large numbers of people that have gone through birthing centers and those who have gone through hospitals supervised by an obstetrician, have not shown a difference in the infant mortality rate. In fact, they have shown a difference in the intervention rate. So the C-section rate is higher where you're being treated in a hospital, but doesn't equate to saved lives. So are there cases where a cesarean section can save a life? Yes. Is that the case for every cesarean section that's done? And does it justify rates of 1/3 or 1/2? No.
What are your thoughts about joint replacement surgery?
Yeah, I think I've kind of covered that. The two most common ones are hip and knee. I mean, there's lots of shoulder replacements, and you can even do ankle replacements and wrist replacements, but these are very, very small numbers. When you're talking about knee replacement alone, that's the most common one. You're talking about nearly 1 million a year in the US, several million procedures worldwide. So this is a massive common operation. I think it's overdone. I think a lot of patients could be treated non-operatively. A good example of this is that the average patient who has a knee replacement is overweight, is obese. Not just overweight, but obese. And we know that obesity is associated with knee pain and osteoarthritis. There's reasonable evidence that getting patients to lose weight can decrease their knee pain, and for maybe, 10% of patients, 15% of patients, they can avoid having a knee replacement altogether. So that's a whole lot of knee replacements that we could avoid if we got people to lose weight. And if we got them to lose weight, it would also affect their other health, their general health. They'll be less likely to have diabetes and all the associations that go with diabetes. So you would be creating this huge increase in health by getting people to lose weight. But often we don't look into that. Someone comes in with arthritic knee, they're overweight. Okay, we'll replace the knee. And we don't say to them, well, look, if you lost, this much weight, 5%, 10% of your body weight, you might not need a knee replacement, and your diabetes might go away, and your risk of heart disease will plummet, and you'll live a lot longer. We often don't have that conversation, unfortunately.
What are your thoughts on broken bone surgery?
It can be hugely helpful. Let me pick an example that I haven't already mentioned. The thigh bone, or the femur, which is the bone between your hip and your knee, is the biggest bone in the body, and it's often broken in car accidents, motorbike accidents, falls, and things like that. And I treat a lot of those injuries and still do. Just before I started my practice, and still with a couple of the old school surgeons when I started my practice, but certainly back in the 60s and before that, these were often treated in traction. So these are young men who came off their motorbike. They would be put in traction in hospital for months. All right, so not working, muscles wasting away, tying up a bed, huge cost. To them and society, their family. They can't look after their family. They're not earning money. They're stuck in hospital for months. The fractures would heal by and large. It's not like they wouldn't heal, but often treating them in traction, they wouldn't heal quite that straight. They'd often be a little bit short, so the patient would be limping afterwards. So there's some functional impairment. But they would get back to society. They'd go home again. I mean, for ages, femur fractures were treated in traction. It's not a complete disaster. But these days we have operations where we can treat that fairly safely. We can do a fairly low risk operation the day they come in, or the day after they come in. They can be home in a few days walking on it. They can actually be taking weight on it with a metal rod. It'll heal dead straight. It'll heal at the same length as the other leg, so they won't have a limp afterwards. And so here's an operation that works really well. Is it completely necessary? Well, no. You can treat a femur fracture without surgery. It's just that it saves a whole lot of time and a whole lot of money and a whole lot of hassle, and that alone is worth the surgery. So yeah, it can be very effective. On the other end of the spectrum, there's fractures that are often treated surgically that probably don't benefit. So wrist fractures are about the most common fracture in older people. You just slip over and fall on their wrist and break their wrist. We just published about 2 weeks ago in JAMA Surgery a study we did comparing surgery for that, where we put plates and screws in to fix it, compared to just old-fashioned plaster. Showed no difference in the results at 12 months. So patients who are treated surgically, yeah, it sounds like a good idea. It's really common, and a lot of hospitals around here and in the US treat all of these cases surgically, or nearly all of them surgically, but there's no average benefit to the patient. You can put them in plaster and they'll do just as well.
What are your thoughts on angioplasty and atherectomy surgery?
Yeah, well, these days, angioplasty surgery is basically stenting. So it's opening up a narrowed artery. Most of it is done for people with what we call in the heart with stable angina. It's done in other areas of the body as well, in the kidney, and other arteries in the legs and that kind of thing. But the evidence for it isn't that good, because for people with stable angina, it's not better to do that than it is to give them medical therapy with drugs. And yet it's still commonly done. So that is a procedure that's definitely overdone. It's been shown now with several studies that it's being overdone, but people are still doing it because when they do the angiography, which looks at the artery and shows that it's narrowed, they just think, well, I'm just going to open up that narrowing because it just makes sense. And they're not looking at the science that says, well, if you do that, it doesn't help the patient any more than if you give them medical therapy. At least for patients with stable angina. They don't think that. They just think, but it's narrowed, I've got to open it up, and surely that's a good thing. It's a bit like, but there's a lump in their thyroid, so surely I've got to take it out. That has to be a good thing. Okay, yeah, sounds good. Let's test it. Oh, it's not good. Okay, let's not do it. But people don't go to that stage. They just say, it sounds good, so I'm going to do it.
What are your thoughts on hysterectomy surgery?
Yeah, hysterectomy is another interesting one. Say you've got somebody, so this is removal of the uterus, you've got somebody with uterine cancer, and you take it out and their cancer's gone. Great. Okay, so that's an area where it could be effective. But it's done for a lot of other things. It's done for people with endometriosis, with unexplained pelvic pain, with benign abnormalities in the uterus that might not be necessarily causing the symptoms. So it's a bit like the back pain question, where there's something there on the scan, but that thing on the scan might not necessarily be causing the back pain. And so it is an area where surgeons have been criticised for overdoing the procedure. And like a lot of other things I've said, is there an area where it might be effective? Yes. But is it being overdone? Yes.
What are your thoughts on gallbladder removal surgery, and doesn't this save lives?
Yeah, I'm not sure. When I did my training, gallbladder surgery was done every day. We would have a ward full of people having their gallbladders out, and anybody who had sort of pain in the abdomen in that region, or all sorts of sort of vague complaints, got their gallbladder taken out, and the gallbladder was blamed for everything. But it's much less common to do it now. So I think it was being overdone. And I haven't looked at that recently, so I don't know what the rates are and whether the rates are going down or going up. So I'm not really up on the evidence of gallbladder surgery, so I'll probably leave that one there.
What are your thoughts on heart bypass surgery, coronary artery bypass graft?
Yeah, there's studies that have compared coronary artery bypass grafts to stents. And for a while there was a little bit of competition between the cardiac surgeons who do the bypass grafts and the cardiologists who do the stenting. And again, when I did my training, coronary artery bypass grafts was very common. Cardiothoracic surgeons made a good living doing that. These days they don't do it so much because the cardiologists have taken all their work away by doing the stenting. Now, there are still cases where stenting fails or where stenting can't work and they get referred to the surgeon, but bypass grafting doesn't have a clear benefit over stenting. And stenting doesn't have a clear benefit over non-operative treatment for many of the patients that are stented, not everybody.
You alluded to this earlier. Wouldn't insurance companies try to stop all these surgeries if they weren't necessary so they wouldn't have to pay for them?
Yes, and they are. So health insurance companies put a lot of effort, lobbying money, research money into trying to find out whether these operations work and trying to change practice where it doesn't. And in the US, they tried to stop doing spine fusions for back pain. In Australia, they tried to stop that as well, doing spine fusions without a clear diagnosis of what's going on. In Australia, they got that overturned. I think they worked their way around it in the US. And so surgeons are still doing it. It's difficult to create rules that are that strict without saying you can never do a spine fusion. Because there's cases, where the spine's been broken or dislocated or something, where a spine fusion is a great operation, or somebody's got cancer in their spine and unblocking the spinal cord and fusing the spine might be very helpful to the patient. So there's examples where spine fusion as a technique is useful or might be useful. So they can't wipe out spine fusion. And so then it just sort of leaves it, makes it difficult to get around. It's a bit like the knee arthroscopy debate. What happened was we used to do knee arthroscopies for people with pain in the knee. And a lot of that was arthritis in the knee, degenerative change in the knee and arthritis. And we would give them a washout or an arthroscopy. And then the first placebo studies showed that that didn't work for arthritis. And so the surgeons kind of changed the goalposts a little bit, and they said, well, it's not really arthritis we're doing it for. We're doing it for the meniscus tear, the degenerative meniscus tear. And so the next placebo study showed that surgery specifically for meniscus tears wasn't effective. It was no more effective than placebo. And so surgeons sort of changed their tune and said, oh, well, it's not so much the meniscus tear on its own, it's the mechanical symptoms that the patient has. They're the ones that really benefit from surgery. And then they looked at more studies and found that even those with mechanical symptoms didn't do any better with surgery compared to placebo. And so people keep changing the goalposts, and it's the same thing with back pain. They're kind of like, oh, well, it's not really the degenerative changes that we're treating, it's the instability, or it's not the instability, it's the alignment. They keep sort of making up reasons as to why their operation might work. And what they're really doing is looking for explanations as to why some people get better after surgery. And they're not considering the placebo effect of surgery or the fact that other factors might be affecting their improvement. When in fact, I think the surgery is probably not effective.
So our next question is why do some doctors think their surgery is more effective than the data suggests? I'm hearing an answer in there. Is there more you want to add to that?
Yeah, to sum it up, I think that doctors are more influenced than what they see in their own experience than what the science would tell them. And so if 2/3 of their patients say they feel better after surgery, most surgeons attribute that improvement to their surgery. And that's a logical fallacy called post hoc ergo propter hoc, which means it follows, therefore it is because of. And so when they see 2/3 of their people get better after their knee arthroscopy or their spine fusion, they think that those people got better because of the surgery. And we know, though, that 2/3 of the people would have got better if they'd have done anything else to them as well. And that's the problem. People can't see past this very powerful human response to see causation where correlation exists, and that they want to see causation, and so they do. They see causation. They see that the improvement is due to their surgery, but scientifically, when we look at that, it's probably not the case. And so it's an illusion.
You said most surgical procedures have not been subjected to blinded trials, which is the least biased measure of effectiveness. And that's what we need to change. Why haven't most surgical procedures been subjected to blinded trials so we learn once and for all which procedures are and aren't effective and safe?
One of the reasons why surgeries have not been subjected to high quality comparative trials is because they don't have to be. So if we wanted to introduce a new drug, we would have to compare it to the best available drug or a placebo drug, or do a high quality randomized trial to find out if it works. That's the only way we would get that pill on the market. So the only way we would get the insurance to cover it, to make it common practice. But you don't have to do that in surgery. You just have to say, this sounds like a good idea, that if I take out this lump, or if I fuse this spine, or if I take out this torn cartilage or whatever, that the patients would feel better. And hey, I've been doing it for a while and the patients seem to like it. That's all you need for surgery. So one of the reasons why we don't have that evidence is because we don't have to. I think a lot of surgeons aren't interested in getting that evidence because they're happy with the way things are. If they were forced to subsequently be paid for that operation, then I'm sure we would generate a lot more evidence.
Why was it important for you to come speak with us here at the Real Truth About Health conference?
For the same reason I wrote the book. I want to get this message out to the widest audience possible. And so I thank you for the opportunity to do that.
Well, we thank you for your very meaningful work, and for joining us as well. It means a lot to us and to especially to our audiences. So thank you. Thank you for your time today. Really appreciate it.
It's been my pleasure. Thanks.
Be well. Take care.
Okay.